the time, so we don't go beyond the allotted time for each item on the agenda. Good afternoon, or should I say good morning, good afternoon, good evening, wherever it is you're joining from. My name is Dr. Tumsia. I'm sure people who have joined earlier, our sessions earlier, are familiar with the face and the name, but then it's still okay for an introduction each and every time. I am the Community Engagement Manager for Farmalat, and you're welcome to yet another session of the telemedicine education series. So today's topic is very, very interesting. I know for everyone, because seeing the number of veterinarians that registered for the session, like it gave me, I was happy to see that, you know, a lot of people are ready to learn, even though we're all doctors, but we just keep learning. The day you die, you stop learning, but as long as you're alive, you keep learning and improving on your practices. So welcome on board, everyone. So our topic for today is, hello, can you hear me? Hello, oh, sorry, my apologies. So our topic for today is contagious bovine pleural pneumonia, the disease, the epidemiology, and then the role we veterinarians have in curbing this disease. So I'll be taking us through the process of this session. As I said, I'll be facilitating. So this tele-education series, basically TECLA, that's the acronym, which means tele-education for clinicians and leaders in Africa. Farmalat is hosting this, supported by MDoc, Boehringer Ingelheim, Making More Health, and Ashoka Africa. It's been really exciting, and oh, I can see Dr. Charles Ibe. Thank you for joining, sir. So today, I'll be taking us through the agenda first. As I said, we'll be very time conscious. Introduction, and then a brief about Farmalat, a brief about Project TECLA. We're going to take a pre-quiz for just 3 minutes, and then the didactic presentation for 15 minutes, and then a case presentation, a real-life case presentation, and then open discussion for all participants, questions and answers. And this is where ECHO model is big on. Like, we're going to take more than 50% of the time to discuss and to discuss around the topic. Your questions and answers are welcome, your comments, your suggestions. So we're going to be doing that for 40 minutes. And we're going to get to recommendations from our hub experts present in the room. And then we're going to also take a post-quiz. Basically, a pre-quiz and a post-quiz is the same question. We just want to know how much you've gained during the presentation, and that's just about it. And then just the summarization at the end of the post-quiz, and then announcements for next sessions, and then any other announcement we have. So I can see our case presenter joining. We have our hub experts joining in. Thank you so much. So I'm going to be giving you some few steps, or let me say guides, just to enjoy the session. So these are the 4 pillars which holds the ECHO model. So ECHO model basically uses video conference technology to leverage scarce healthcare resources, specialists sharing best practices with colleagues, case-based learning, and continuous monitoring of this program's outcome. Next slide, please. So please take note, Project TECLA leverages the ECHO model. We collect registration, participation, questions and answers, chat comments, poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel. These data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and also to inform new initiatives. So the session will be recorded, is being recorded, and we'll be sharing PDF version of the slides after the session. Thank you. Next slide, please. So these are the participation tips. Please have your camera on. The facilitator will unmute you when you need to speak. And then please use the raise hand feature in the Zoom when you want to speak. And then kindly use the chat function for any questions. We have people specially designated to extract your questions and your comments, and they'll be attended to. Thank you so much. So this is a beautiful, as I said, Familart is hosting this teleeducation series, and Familart is all about enabling easier access to affordable animal health care. So that's it for the introduction. Let's move to the next agenda. Let's move to the next item on the agenda. Please, the agenda. So a brief about Familart. Dr. Femi Kayode, can you please take over and just give us a brief about Familart? If you're not available.
Right. No, okay. So I could.
Okay. All right. Welcome.
Afternoon, Dr. Tumsia.
Good afternoon.
Good to have you, and thank you for the good job you're doing for us or the animal health social enterprise. As you have clearly stated, what we want to do and achieve in Familart is to ensure that there's easy access to affordable animal healthcare, million people. In 2050, we will be 400 million. So it's been estimated. The food system in Africa currently is weak. With increase in population, I suspect that it will be weaker. So if there are no intentional efforts to food system, so if there are no intentional,
I think Dr. Femi is having issues with his network.
Efforts to strengthen the food system. All right, so it's my pleasure to welcome everybody to this today's ECHO, and I think Dr. Tumsia is capable enough to handle every eventualities. Please do have a wonderful session ahead. Thank you.
Thank you very much, sir. So that's a brief about Familart, and I'll be bringing on somebody from MDoc, Adora or Olabisi, to please give us a brief about MDoc, just for 2 minutes. Just give us a brief about Project Tekla. Adora or Olabisi. Okay, let me just give some few seconds. Oh, okay.
Hi, everyone. Hello. I was trying to unmute myself. I wasn't able to do so. Hello, everyone. Apologies for having my video turned off. My network has been acting up, so I'm trying to manage the bandwidth. Welcome, everyone. My name is Adora. I'm a senior manager with MDoc. MDoc is a digital health social enterprise. And one of the key things that we do is capacity building, trying to ensure that we contribute to the quality of care. And through our work in our quality network, we leverage the ECHO model to provide these capacity building opportunities. And we've done that in partnership with the University of New Mexico ECHO, and that partnership has extended to even many more social enterprises, one of which is Familart. And so we are leveraging this ECHO model to provide capacity building opportunities and to pretty much steer the conversation around quality and improve the quality, both around human health and now around animal health in partnership with Familart. So we're happy to be part of this session, and we look forward to having even many more exciting sessions. Welcome, everyone. It's going to be an exciting one. Over to you, Dr. Tumsia.
Okay, thank you, Adora. That was a beautiful brief. And then I would love to say this, we said it earlier, Familart is actually the first in the animal health space to leverage the ECHO model. So we're going to take, quickly, we're going to take a pre-quiz, as I said earlier. So the pre-quiz is just some simple questions, 5-10 questions thereabouts to help us gauge the knowledge shared and gained at the end of, before and at the end of the presentation. So a poll will be up, and I'll implore each and every one of you to take these questions. We're going to have this for 3 minutes. So the time starts now. Thank you so much. Okay, we can all start taking the quiz. It's just to help us measure what we've gained at the end of the session. So I implore each and every one of us, it's on your screen. You can just answer the questions and we can get down to the presentation, to the didactic presentation. Okay, I haven't seen anybody attempt. It's 37 seconds away. And so I implore you all to please take this quiz. They're just simple, straightforward questions. You're answering it based on anonymity. So your names are not actually going to pop up and nobody's going to come for you at the end of the day to ask why you failed or why you scored a very high score. So it's just to help us. Yeah, I can see someone taking 2 people. Okay, we're 1 minute away. Just 5%. This is okay. Yeah, this is coming on well. Just keep answering, keep answering. Thank you so much. Welcome everyone on board, our hub experts, our case presenter, and everyone else. You're acknowledged and appreciated. Thank you. So we're just all about knowledge sharing, bidirectional knowledge sharing, and that's why we're big on discussions. After the presentation, we're going to have 40 minutes to take discussions, questions, and answers. Okay, I can see it going on well. 36% participation, 1 minute, 42 seconds gone. This is going to go for just 3 minutes. So please do participate in answering the questions. It's actually fun. Yeah. Okay, we're 2 minutes gone. We have just literally 1 minute away, and then we're taking down the poll quiz. But before then, please do participate. Yeah, 50%. I'll need more. So yeah. Okay, just 50%, and then it just stopped. Please get, okay, yes, okay, it's coming up. I guess a lot of people are listening. Yes, 59%. I'll be needing more. I won't mind 70. You know, I said 50, but then we all want more. So we just have some few seconds to go. This is good. 60% is good. Okay, few seconds. And then we'll take down the quiz, we'll take down the poll. 62%, that's encouraging. Yeah, so we have 3 minutes. Can we just end the poll and move to the next item on the agenda? So we had 65%, but after the can I have the screen back on, please? We can take down the poll quiz. The poll has ended. Okay. Okay, so we have, for today, we have Professor, as one of our hub experts, we have Professor S.O. Okayetu, forgive me, sir, for any mispronunciation, who is a, Prof is a professor of veterinary infectious disease with specialty in food animal practice with over 30 years of experience. He is currently the head of the Fulani Ambulatory Unit of the Veterinary Teaching Hospital, Ahmadu Bello University, Zaria. And then we have the other hub experts as Dr. Can I have the screen, please? Okay, we have Dr. Mohammed Babashani, who is a lecturer, Large Animal Clinic of the Veterinary Teaching Hospital, Ahmadu Bello University, Zaria. He's also the breeding consultant for SAJ Foods Limited, Zaria, and a large animal practice mentor to a lot of young veterinarians that I can attest to. welcome and thank you for sparing out time to share your wealth of knowledge with us. So straight to the didactic presentation. Dr. Mohammed Babashani, the floor is yours for 15 minutes. Thank you very much. Over to you. Okay, Dr. Babashani, can you hear me?
Okay, can you hear me?
Yes, we can.
All right.
Welcome. Good afternoon, sir.
Thank you very much, Tunisia.
Yeah, thank you, sir.
Okay.
So over to you. So you have 15 minutes.
All right, so thank you very much. Can I have my presentation up?
Yes, we'll have the IT support control the slide, if that's okay with you. Yeah, so the slide will be up.
Okay.
Yes. And then, yeah.
Okay, thank you very much. So, good afternoon, everybody. We'll be talking about a very important production disease, the contagious bovine pleural pneumonia, which is a very important disease to all livestock farmers, cattle farmers in Nigeria. Oh, can we move the slide to the next? Okay, so we'll look at a brief overview of the disease, the epidemiology, that's the distribution across the world, etiology, transmission, clinical manifestation, then the pathology, then how to diagnose it, then the economic impact of the disease, how to prevent it, and what are the next steps. Next. So CBPP is a highly contagious infectious disease affecting cattle and water buffalo. The first report of the case was in Algeria in 1873. It has been spread all over the world since then, and it principally attacks the lungs and the membranes of the lungs that line the thoracic cavity, that is the pleura, causing fever and respiratory signs. It is highly contagious, as I've stated earlier on, with mortality rates exceeding 50%. It causes great economic losses. CBPP is a reportable disease and is listed by the OIE code for terrestrial animal health. Next. Okay, this is the distribution across the world. The purple and orange colors indicate that we have confirmed cases of CBPP. So you can see it ranges from Africa, Middle East, and Europe. Next. The disease is caused by a higher bacteria, Mycoplasma mycoides mycoides. Initially, it was thought that only the small colonies are able to cause clinical disease, but it has been found that even the large colonies can cause clinical disease, as the bacteria was isolated from the fluids of the thoracic cavity of infected cows. Also, interestingly, it has been found that the bacteria has been isolated from aborted fetus, which suggests it might have a role to play in reproductive diseases. The organism has also been isolated from captive wild goats, as well as camelids, which might suggest their role in the epidemiology of the disease. Next. So how is it transmitted? Transmission is mostly by direct contact between infected cattle and susceptible hosts through inhalation of droplets disseminated by coughing of the infected animal. Also, carriers of the organism has been confirmed to spread the disease within contact animals. There's no evidence of transmission through fomites such as human hands or other inanimate beings that can serve as a, there's no confirmation that these fomites can transmit the disease. Next. So what are the clinical signs? The clinical forms of the disease are divided into 4. You have the hyperacute form, which is in about 10% of infected hearts. The principal thing you'll see in the hyperacute form is that the animal is found dead overnight without premonitory clinical signs. Next. In the acute form, which affects about 20% of affected cattle, the onset is acute and the course of the disease lasts between 5 to 7 days. Principal signs you see here include pyrexia, signs of pneumonia, abducted forelimbs, rapid abdominal movements, reluctance to move. We'll also see development of a shallow, dry cough, which is painful to the animal. And there's also exercise intolerance. Other signs include mucopurulent nasal discharge, stretched or extended neck, and then we have seen a lot of cases presented with bloat, and this is mostly as a result of inflammation of the vagal nerve resulting from pruritus. The subacute form occurs in 40 to 50% of animals, which present with signs of the acute form, but it's usually milder. And we'll have what we call recurrent fever. Sometimes if you take the temperature, it will be high, other times it will be low. Then the last form is the chronic form, which is as a result of a natural evolution from both the acute and subacute stages. Clinical manifestation gradually decreases. So mostly what you see is wasting of the animal with just occasional fever and then loss of appetite. In young calves, we have seen cases of polyarthritis, and then which results in lameness. Next. So on postmortem examination, usually we'll see diffused signs of pneumonia, hepatization of the lobes of the lungs, and the marked pleural effusion and fibrinous pleuritis. There's extensive pulmonary edema, especially in the acute form. And then you have formation of sequestra, which is encapsulated necrotic pulmonary lesions, as shown in the figure by the side. This is usually referred to as the marbled lungs, which is a consolidation of the lungs of affected animals. This is classical of CBPP. Next. So how do you diagnose the disease? Diagnosis is usually in the field, we rely on clinical examination and postmortem lesions. But to confirm it, you need to submit samples to the lab. Serological tests like complement fixation test and ELISA will give you suggestive confirmation, but culture and then PCR confirmation is the most reliable of the tests. Okay, next. So what is the economic impact of the disease? CBPP has great economic impact on the livestock industry. We have an estimated $2 billion loss due to CBPP in some African countries. In Nigeria, it is estimated that 2.2 billion naira is lost annually as a result of CBPP. And Nigeria, in combination with some states in Nigeria, particularly Sokoto and Kano State, in combination with Niger Republic, has reported annual losses of over 220 million naira.
Okay, Doc, we have just 5 minutes to go.
Okay.
Yes, yes.
So my slide is, I'm no longer seeing it.
Okay, it's back on.
All
yes.
right.
Apologies.
So next slide, please. Okay, I've told you about the economic impacts. Next is how do you control this disease? So control strategies as documented by Alhaji et al. 2020. He recommended 4 control strategies: vaccination, treatment with antimicrobial agents, movement control, and then stamping out. So so far in Nigeria, the most effective are the 2, treatment and vaccination. However, there are problems related to vaccination. Number 1, there is low vaccine coverage across the states that have the highest cattle populations. For example, in Adamawa State, France is reported as low as 20% coverage. And then we have the highest coverage I've come across is in Kano State, where they have up to 60% vaccination coverage annually. However, the main problem with vaccination is that you vaccinate animals within these states, and because it's a transboundary disease, animals that are not vaccinated from foreign countries can troop in. And then the cycle becomes a vicious one, because you vaccinate animals and you have animals that are not vaccinated introduced. Another problem with vaccination is that the vaccinal strain is likely not the same as the one that is in circulation in the field. So this constitutes another problem. Treatment, over the years, we have instituted treatment with various regimens. For example, thylacine has been used and abused by farmers, oxytetracycline, and then we have newer antibiotics such as the nitrofurans. Example is danofloxacin. To control the disease, we have to also institute policies that would prevent transborder movement, or at least make sure that animals that will be moving into Nigeria will be fully vaccinated. The stamping out principle has been introduced in Nigeria. However, it's not effective because of lack of compensation in the part of the government. So next, I'll talk about the antibiotic treatments. Literature has shown that antibiotic therapy has reduced the infection rate by 50%, and as well as the mortality rates. However, there's still problem with formation of lungers, which serve as carriers of this microorganism. So as long as they are lungers, then the infection will persist in the farm, and it becomes an endemic problem. It's already an endemic problem, and it's difficult to eliminate from the population. Next. So advocin is an antibiotic that has been tried, and it has reduced mortality by as low as 40%. And then it has also been shown to reduce the spread of the disease within farms. So this is a very important antibiotic that requires more research work. What are the setbacks related to the use of antibiotics? It increases development of resistant strains, because most Fulani people that use antibiotics, they give sub-therapeutic doses, and this leads to development of strains that are resistant. So proper use of antibiotics is necessary. Then also it encourages formation of sequestra, in which you have increased number of carriers in the herds. Next. So what does the feature entails? So we have we still have to continue with vaccination. And we need to develop newer vaccines, for example, the DNA vaccines, which will target specific proteins and molecules on the surface of the bacteria. Together with the human doctors, we're vaccinating at concurrent times. So for example, human doctors will go to vaccinate against polio. Immediately they finish vaccination, the hearts will now be gathered for CBPP vaccination. This will cover a lot of areas. It would increase the vaccination coverage. Also, we have to continue developing newer regimen for treating clinical diseases. In the veterinary teaching hospital of ABU's area, clinicians have shown increased elimination of clinical signs with the use of oxytetracycline and dexamethasone. So we have to continue clinical trials in order to successfully eliminate the disease. So the take-home message is we have to increase vaccination coverage, newer vaccines, then more research into the development of antibiotic therapy, as well as government policies that will prevent transborder movement of animals without vaccination records. Thank you very much.
Thank you very much, Dr. Babishani. That was a beautiful presentation. And I'm sure we all have questions around it. So you can start preparing your questions, your comments, and your suggestions. So we'll be moving to the next item on the agenda, which is a case presentation by Dr. Robert Joshua, who is a private practicing veterinarian. So Dr. Robert Joshua, you have 5 minutes to quickly take us through a case of CBPP you handled. The floor is yours. Dr. Robert Joshua, you have 5 minutes. Thank you. Can we have the screen up, please? Okay, Dr. Joshua, are you with us? Okay. Okay. Let's give him some few seconds.
All right. Hello.
Oh, okay. Good
afternoon, everyone. Yes, I was muted. I could hear you, but then, yeah, thank you very much.
Oh, welcome and thank you. So the floor is yours for the next 5 minutes.
All right. Thank you very much. Thank you for the privilege and the opportunity. Just going straight to the point. The case I want to present here is just a case of management of a case of contagious bovine pleural pneumonia in a cow. This case was handled in the field, not on a farm actually. And then the case overview here we have is history, clinical presentation, diagnosis, the plan, the management, follow-up, and then we'll also get to the conclusion. Next slide, please. All right. On this date, 10th of October, I was called upon to attend to a cow. We just returned from the grazing area. Usually, these herders take their animals to a grazing area where they spend a long time there. Sometimes it may take the entire rainy season before they return. So, but this cow had this case, and then I was told it returned like 2 days ago, and then they called me to come and attend to it. And then after getting to the community, I was told the cow was 3.5 years old, and then I asked of other medications and what they have done to this cow, what other medication they've administered to this cow, and I was given a list of drugs which included 10 mils of oxytetracycline, which they commonly called LA, 10 mils of xylosine, and then 100 mils of albendazole. Next slide, please. All right, on our examination, these were the signs I noticed. The 4 limbs were adopted on arrival when I was, and then there was mild epiphora, and then we have oral and nasal discharge also. That's a picture. And then there was difficulty breathing. And then the head was lowered, the body condition was poor, the animal looks emaciated. This is part of the animal, the body. Next slide, please. All right, and then the animal was depressed, the hair was raised, there was anorexia, there was bruxism, there was bruises on the body, which I later realized it was as a result of the transport. And then there was also pyrexia, the temperature was 40.2 degrees centigrade. Other signs that we may likely come across, I just included this, were slightly arched back. I didn't see this sign personally in the field, but these are other signs that we may likely come across. Slightly arched back, elbows are tucked out, and there's percussion, there's pain on percussion of the chest, rapid respiration. The respiration is shallow and it's also abdominal. The cough is moist, then there's also grunt that is heard at expiration. Next slide, please. All right, then I thought of differentials even after seeing those signs. And the differentials I came from foot and mouth disease. I wrote this out because of the, sorry, this is a typographical error here. I wrote this out because of the absence of oral and foot lesions. That was why I ruled out foot and mouth disease. And then I consider shimmy fever because of the head and the neck that was extended around the edge. The discharges are also sore from the mouth and the nose. And then I also consider bovine tuberculosis. Next slide, please. My plan was to advise them to isolate and quarantine this cow immediately, and then also to begin treatment, and also to advise and sensitize the farmer on the impact of this disease. And then also to advise them on the irrational use of antibiotics, and plan towards provision of metaphylaxis for the herd that's still in the grazing area. And also to report to my upline for confirmatory diagnosis, because this is a reportable disease. Next slide, please. All right, my treatment plan included enrofloxacin at 2.5 milligram per kg per day for 3 days consecutively. I also administered multivitamin, 15 ml. This I did twice in a week for 3 weeks, and then I advised them to isolate, feed, and water this cow separately. And just to add to this, next slide, okay. I'll come to that. All right, the follow-up, 48 hours, that's 2 days after I began treatment. There's improvement in the appetite, and then at least when it's presented with bran, he can eat up some feed. Then the temperature also, I noticed the temperature also was within the normal range, even though it was on the high side. And then the respiration too, there was improvement. Next slide, please. So I recorded much improvement later on. I think that was about 10 days later from the animal, and these were the pictures I took. There's so much reduction from the discharges. Next slide, please. All right, and then 2 weeks after, when I visited the community, I was shown images of this very cow. This one happened to died while they were in the grazing area. So they took the pictures and sent it through WhatsApp to the community. It was when I get there that I was shown this image. So the following images will be seen are what are the images that they got from the animals they lost in the field. They lost about, in total, they lost around three animals in the herd, just from the herd alone. So this was the lungs they were sent. Next image. All right, this also the lung picture. Next slide, please. So these are images of just the lungs that were. So in conclusion, CBP is a reportable disease, and it causes great economic loss. Field diagnosis is quite difficult, and science are not really particular of these diseases, and treatment is also becoming challenges due to irrational use of antibiotics in the field, especially by herders. Next slide. All right. So I just recommended this so that in line with, together with clinical signs that we may come across in the field, there's also there are rapid tests kits I've come across actually in the internet. I have not had access to use any one of them yet, but it's based on ELISA. So, but I believe if this can be used, because since it's a screening test, if this can be used together with clinical signs we'll come across in the field, it will help a lot in diagnosing this condition in the field. Thank you for listening. Next slide. All right, thank you for listening. Okay. Okay.
All right, so thank you, Dr. Joshua, for a well thought out case. So right now, before Dr. Tumsia comes back and take the question and answer, I want Professor Kaito, with his 30 years experience, and more importantly, handling the Fulani unit of the ambulatory process for Ahmadu Bello University Teaching Hospital. Prof, sir, can you just take another 3-4 minutes and just give like an overview experience sharing of what you encounter on the field and why this disease is significant before Dr. Tumsia comes up again and take questions and answers.
Thank you very much. I hope you are hearing me. Are you hearing me? Hello?
Yes, Prof.
Okay. Thank you very much. CBPP has been a disease that has been with us for a very long time.
You look far away from your laptop or your device. So if you could move slightly closer.
Can the host unmute him?
Yes.
No,
Okay.
All right, can you hear me now?
Loud.
Hello?
Yes, we can hear you, but yes, looks like you're in the same place with Dr. Babashani.
Oh, it's a bit far away from me.
Okay, all right, then you can go ahead.
Yeah.
You can hear you.
All right. Like I said, CBPP has been with us for a very long time, you know, and I have been privileged to handle several cases on the field. But then let me correct one narrative when Dr. Babashani was doing his presentation, you know, because the theological agent of CBPP, Mycoplasma mycoides or species mycoides, you know, we used to attach either large colony or small colony. That has been removed. So the theological agent remain Mycoplasma mycoides subspecies mycoides. Thank you. Now, back to cases that I have seen. I have seen quite a lot. Some of them very, very pathetic, you know. Let me give you one instance. A nomadic man went to NVRI or went to Jos and purchased 20 vials of CBPP vaccine. The man had just about 50 animals in his herd. He got to his house, constituted the vaccine, and he administered these 20 vials to his 50 animals. Unfortunately for him, all of them came down with a severe case of CBPP. He came running to us in the hospital. We paid a visit to his farm. We just looked at him in the face and said, sorry, there is nothing we can do. He virtually lost all his animals. Okay. Now, CBPP is a disease that does not, you know, respond to treatment. And I will explain the reason why. And that is why, you know, when we are discussing treatment, tylosin, oxytetracycline, I just frowned at it. because it explains the reason why the disease has been endemic in this country. All right? Once the lung is seeded by the organism, Mycoplasma mycoides or species mycoides, establish itself in the lung, release certain polysaccharides, otherwise known as galactan. This polysaccharide, with some enzymes, necrotize the tissue around where the real organism is, staying. For that reason, it forms a capsule, and that capsule is polyvascularized. No matter the amount of treatment you give, the treatment you gave will not get to the seat where the Mycoplasma organism resides. So you end up having a carrier, and it is this carrier that continues to shed this infection in the heart whenever there is stress. So I personally have, been trying to discourage treatment. What happens when you visit a heart and you discover that one animal in the heart is infected? What you do is you isolate and quarantine that animal. You do nothing to that very particular heart. You pay a visit again and keep telling your client that for anyone that shows sign or are lagging behind during grazing, please isolate. You keep isolating until no additional animal, shows sign of getting new infection. And then you give a grace period of about 2 weeks, then you vaccinate. That is the only way we can control this disease. But the moment we start using treatment protocol, honestly, sincerely speaking, we are killing ourselves. We will continue to remain with the disease in this country. So that is it. And what is happening right now in the field is that a number of times you find animals getting infected with CBPP with other concurrent infection. So the problem is that we have to find out, apart from CBPP, does this animal have other infection? Like the case the doctor handled. We need to know the environment where he handled that case. All right? If the environment happens to be area that you have Aedes flies abound in the place, then of course you cannot rule out African animal trypanosomiasis. And I've seen several cases of mixed infection, concurrent infection of CBPP and trips. Okay, so a number of times, you realize that the trips will be there, the trip will suppress the immune system, and before you know it, once there is a pocket of infection in the heart, the infection will spread. All right? So that is it. So our main problem or our main emphasis on how to control the disease is by vaccination. However, we have problems with our vaccines. I have a PhD student who has just graduated. He did his survey in the southeastern state of the country. And we realized that we have different serotype of CBPP organisms in the field, which are completely at variant with the strain that the vaccine was produced. Okay, so you have a scenario whereby you have your vaccine, which is completely different from the strains that are in the field. So you go there, you vaccinate, and of course, nothing happens. So we must, work harder, establish the strains of CBPP organisms that are out there in the field. And then, of course, NVRI will have to go back to the drawing board and see how they can produce a polyvalent vaccine that will take care of all the serotypes in the country. That way, we are making a step. Thank you very much.
Thank you so much, Prof. That was really interesting, listening to you with all your suggestions and recommendations. It's, as I stated earlier before the session, I promised all of you are going home with valuable information. Exactly. While you were presenting, I noticed the president of the Veterinary Council just joined us in person of AIG, Aisha Tubaju. Yes. Thank you for joining, Ma. And I also noticed Professor Abdullahi Magaji. I'll have to recognize him. He was the dean while I was in school. And I also noticed Professor Caleb Kudi and Dr. Ada Ogochi from Zoetis, who is also a prominent practitioner. So the ECHO model is big around discussions, questions and answers, so that we can all go home with better knowledge and better information about what we know. So we're going to open the floor for comments, questions and answers. So please do utilize the chat box and also the raise hand function. I'll unmute you where there is need for you to speak. And please, you can get your questions coming. We have somebody specifically extracting the questions. So please do. Okay, we have another question here, and I'm going to channel this question to Professor S.O. Okaetu. They said, is there anywhere in the East that these vaccines can be obtained, sir? Hello, sir. We can hear you, you're muted. Can we unmute Prof, please? Can we unmute Prof, please? Okay, I think we'll just go on because of time.
I think Prof can unmute himself.
Okay, he can unmute himself. Okay, Prof, you can unmute yourself.
I just did it now.
Okay. So the person asked, is there anywhere in the East where these vaccines can be obtained?
Yes, NVRI, National Veterinary Research Institute, they have outstation in virtually all the states of the Federation. So there you can access any type of vaccines that you want, as long as, they produce these vaccines. So that is it. They are there. I may not know the particular location, but you can find them in the zonal offices, outstations.
Okay, so for a disease that can be prevented by vaccination, a lot of questions are coming around the use of vaccines. So somebody here is addressing this question to you, Prof. Sir, and they said, while you were giving recommendations on when animals in the herd have been noticed to be presenting signs, which of the groups should be vaccinated? Is it the ones that have been isolated or the free groups? This was a question from one of the participants.
Okay. Please listen to me. What I said, was that the moment you are able to identify a pocket of infection in a herd, you isolate. Now that herd becomes highly susceptible. You don't treat, you don't vaccinate. However, when you isolate, you give a quarantine period of 14 days. During that period, if no single animal show any sign, then it is assumed that the herd is clean. Then you can go ahead and vaccinate. But of course, you know the danger of vaccinating an animal that is infected. If you do that, the animal will come down with full-blown infection. So you must observe the quarantine period of 2 weeks. Thank you very much.
Okay. So somebody is asking here, most of the questions specifically are addressed to Prof. Sir. So I would address these questions to you because most questions are coming to Prof. So somebody said, if animals are isolated as recommended without therapeutic intervention, it means we can allow some of these animals to succumb to the infection. This can lead to significant economic losses. So how do you propose farmers go around this?
See, it is rather very unfortunate, because CBPP is a very deadly disease. Once you isolate far away from the animal, from the herd. The person that will feed this animal will have no business with the remaining animals, okay? And there is nothing you can do. At the end of the day, you have to advise the animal to be salvaged if truly the disease has to be controlled. Because the issue is that if you administer antibiotic, either advocin or tylosin or oxytetracycline, what guarantee do you have that you will have 100% curative? At the end of the day, once you have a carrier, the moment you introduce this same animal into the herd, once there is stress, it will continue to shed this mycoplasma organism among the herd. And remember, if you have an animal, this transmission is via aerosol. Animal within 200 meters can pick the infection via aerosol. So we have to be very, very careful. All right. So the main emphasis, is that, well, the animal has to be salvaged. There's no two way about it. If the herd has to be clean of CBPP. Thank you.
Okay. Okay, sir. Thank you for that explanation. So this question goes to Dr. Babashani. Somebody is asking from your presentation, you made mention on the use of dexamethasone as one of the treatment regimens. But he said the use of dexamethasone should be a great concern to us as veterinarians. So he said, please, can you shed more light on the use of dexamethasone as one of the treatment regimens for CBPP? Dr. Babashani, this question is for you.
Okay, yes, I've reported that people have used it. The advantage of using dexamethasone is it increases tissue perfusion. So when antibiotics are used in the lungs that have been sequestrated by the organism, it increases the tissue perfusion so that the antibiotic will reach some of the target cells. That's the advantage of using it. However, it comes with its own disadvantage. Apart from lowering the immune system, if the animal is pregnant, it will cause abortion in such animals. But as I said, people have used it in the field and it has given them results, although it's not sure whether it has cleared the organism or not, because we have not carried out studies to investigate that.
Okay, thank you for that, Dr. Babashani. I hope the person who asked the question got some clarification about the use of dexamethasone as part of the treatment regimen for CBPP. So, Professor Eso Okaito, sir, a lot of people are asking if they can get a vaccination protocol to abide by. Let's say, okay, at what age, when to vaccinate, how to vaccinate. So, like, let's say establishing a vaccination protocol for CBPP, I think that would be very helpful, and that would be that would be a handful of take-home information for veterinarians on the platform.
Okay.
Yes,
okay. Let me quickly give a rundown. Now, you vaccinate cows. If you're in an endemic environment, you can vaccinate each 3 months. Okay? Then thereafter, it becomes a yearly event. That is, every year you vaccinate. Now, most of the problem is usually how our vaccines are handled. Vaccine must be stored at 4 degrees centigrade from the point of production to the point of administration. In other words, the cold chain must be maintained. And CBPP organisms are heat larvae. They are easily destroyed when there is a change in ambient temperature. So the cold chain must be maintained. And then, of course, the type of diluent you use is very, very important. Now, if you choose to use distilled water, yes, you can use it, but you must administer your vaccine within 30 minutes. Otherwise, the vaccine will be inactivated. The best diluent that you can use for vaccination is normal saline. Normal saline is isotonic to plasma fluid. So when you suspend your vaccines in normal saline, and then of course you use amber color bottle that will reduce the intensity of sunlight in your vaccine. Then of course you have a leverage of a longer period of time to administer your vaccine. Then of course, it is like I say, it is an annual event. Every year, you administer, because the immunity conferred by the vaccination is not permanent, it's not solid. So you vaccinate, Next year, you have to vaccinate again, all right? So, but you must administer that vaccine very well. In other words, you must give subcutaneously. If you made the mistake of giving intramuscularly, that is when the animal is struggling, you jab your needle, you are going IM. And the moment you go IM, the body will recognize the vaccine has antigen and then mobilize inflammatory cells. And before you know what is going on, within 1-2 weeks, there will be massive swelling at the site of administration of the vaccine. A lot of animals have been lost in that process. Okay, so you have to be very, very careful. Maintain cold chain, use correct diluent, and then of course you are in good shape. Thank you very much.
All right, thank you so much, Prof. But looks like you wanted to make a comment around the dexamethasone that Dr. Babashani
okay, yes. I have, in a very bad scenarios, I have reasons to use dexamethasone, but then you must not administer it more than once. You know, because you know that dexamethasone, just like Babashani says, it enhances tissue perfusion. The whole essence is that you have achieved high plasma level when you administer your antibiotic. You want an agent that will dilate the blood vessel, allow more blood to go to the lung, so that even those microcapillaries, you know, in the lungs will be more functional to carry your active antibiotic into where the microorganism is located. That is the essence. Thank you.
Thank you. Sorry, my network bumped me off, but I'm back. So we have more questions coming for you, Prof.
Please,
and I will give it to you specifically. Somebody from the audience said he had a conversation with one of the researchers because you recommended the vaccination at 3 months and then subsequently a yearly booster be given.
Yes, yes.
He had a conversation with one of the researchers at MVRI, and the researcher told him that the level of the antibody drops after 6 months. So it is recommended to repeat the vaccination after 6 months. What's your take on that, sir?
No, we have to understand that we are using a live vaccine, live but attenuated. In fact, wherever vaccines can reverse to virulence. Okay, so you have to be very careful, okay? Like I say, in an endemic environment, we have reason to vaccinate cows as early as 3 months. But in a non-endemic, you do vaccination at 6 months. Okay, so that is it. That is the protocol. All right.
Okay, so that means the vaccine is a vaccine protocol, but then you also have to put into cognizance the endemicity of the disease in the area.
Exactly.
Okay, so I hope we all got that. Though before we call it a day, we're going to give Prof 5 minutes to give us his recommendation. So you can get your pen ready and your paper, and then Prof will give us his recommendation on plan of action in case you have a suspected outbreak of CBPP, the vaccination protocol. So we're going to come back to that because we're getting recommendations from him.
Okay.
So let's move to other questions. Most of the questions, somebody here is saying, I'm going to direct this question to Dr. Babashani. He said, how a participant is asking, how do you advise the nomadic herders to effectively isolate suspected cattle, especially during migration?
Wow, that's a tough one because you can do it, but it's not that they will follow your advice. The first thing they usually do once they have cases is to go and buy drugs and start injecting. If you look at the case that was presented by Dr. Babash, they said they injected 10 adult cattle. Of course, that is therapeutic. So, but with you can utilize extension workers. Yourself as vet can serve as extension workers to educate the farmers on the needs for isolating sick animals and then notifying the veterinarian. Of course, the veterinarian has also to report because CBPP is a reportable disease. But I doubt if most of us report diseases to the right authorities. So the first thing to do is to educate them on the need for reporting the disease and the dangers of allowing the animal to continue grazing with the others. as well as dangers of spreading to other herds. So that's important. Another thing is, as I said, extension is very vital. Most of these herders walk around with their radio sets. So the use of media houses to educate them on all these things is very important. I don't know if Prof has more to add from his experience.
Okay, Prof, sir, I think it's an important question because even on the farm, you find it very hard to advise farmers on how to isolate their sick animals, talk more or less of the nomadic herders moving on this. Yeah, so sir, what's your take on that?
No, the issue is that you as a vet, you visit this farm from time to time. You are the one that make a diagnosis of CBPP. Okay, for the client, except of course those that are well experienced and well endowed. Once an animal is sick, they know that yes, it could be CBPP, it could be ABCD diseases. But then advise them that they have to isolate. If you ever visit a Fulani herd, the Fulani herd is an open land. If not because of the insecurity that we're having now, isolating an animal far away from the herd, it's not a big deal. They should be able to do it. It's a question of getting few sticks around, tying them around, and then with a gate, they drive these animals in. Or alternatively, if they cannot do that, once the animal is established that is CBPP positive, get rid of the animal. Then you are arrested from the trouble. Sorry, somebody posted a question. I just read it. Permit me to answer him for her.
Okay, Prof.
All right. The person said, when you want to dilute CBPP vaccine, you get 100 ml bottle, put your diluent, and then you constitute, and then you administer 1 ml subcutaneously. That is wrong. Very, very wrong. You did that because of ease of convenience. You want to administer 1 ml. The correct, protocol is that the NVRI that produce a vaccine, if you read the label, they said dilute in 50 mils of normal saline. Now, each bottle has about 10 raised to power 7 number of microbes. If you overdilute, by the time you are administering your vaccine, you are given an overdiluted vaccine, which the amount of microbes you are depositing in the animal might not be enough to trigger immunologic reaction sufficiently that will protect the animal for the number of period it is meant for. So that is it.
We have another question. Somebody is asking that rather than repeating the yearly dose, is there a way one can check for the immune response? Just the way you, just like seromonitoring for antibodies, is that also obtainable? Is it practical?
Yeah, it's practical, but then the antibody you check and see might not be sufficient to be protective. Okay, so because the antibody decreases with time. By the time it's 9 months, the level of antibody titer you find in the body of the animal is not protective. So you have to administer again. It's like you are giving a booster every year.
Okay, sir. So the advice is just, yes, I'm with you. Because I guess the person is asking rather than repeating the vaccine on yearly basis, is there need for, but with what you've said, I hope the person has gotten a better clarification.
That is not to this thing.
Okay, all right. So somebody here answered about someone who asked of the availability of the vaccines. I don't know if the person read it,
no,
but the person said they have. No, I'm actually reading out what somebody suggests. Somebody said they have sales reps. They have sales reps all around the country who are available to supply you with these vaccines.
Exactly.
So we have a lot of our professors and our senior colleagues in the house. So I've not seen anybody use the raise hand feature. So if you have a suggestion or an input on this particular topic we're discussing today, please feel free to use the raise hand feature. I will unmute you and you can give us your take, because we have 40 minutes for the for this discussion, and we've eaten out more than 50% of the time. but we can also take more questions and more suggestions. Somebody is asking, Prof, that how do you use aminophylline?
Well, aminophylline is a bronchodilator. I have never used it. What is the aim? To dilate the bronchioles or what? So I've never used it. So I don't think it has any added advantage. You know, it's a drug that is being used, you know, to control asthma in humans. So I don't think it will find a place, you know, in veterinary medicine. I've never tried it, you know. So that's
okay. All right, let me see. I can see, let me check. Okay, I can see Dr. Charles Ibe and Dr. Ada Ogochi. So I'll give you each 1 minute, that's 60 seconds to quickly give us your input. And on this case, so Dr. Charles Ibe, the floor is yours. I just asked to unmute you.
Yeah, thank you. You did not deface me today, sincere. Thank you. Quite a long time.
A real long time indeed.
Honestly, when I look at you and look at your history from your humble beginning, I feel proud of you. And you know what I mean. These young ones will not know what I mean. You see, Okaito, you made one statement here. You see, you know, science evolves and revolves. Because why studying mycoplasma, even to the poultry level where I am now, I'm not in the larger animals. I'm only here for convenience. The organisms, are they still are they still molecules?
No, they are. They are molecules.
My idea of all the organisms are molecules because we monkey with some in poultry like CRT. My idea is that they are very pliable and they are very fragile, just like an egg.
Oh, yes.
Just like an egg without an eggshell. And do they still maintain the egg yolk appearance in their, anyway, you're not a egg yolk appearance in their selected media? Okay.
The thing about mycoplasma, yes, it's very fragile. You know, it doesn't even have a cell wall.
Yeah, let me land because if they are very fragile, and you are saying that you travel some kilometers, close to 100 meters.
Aerosol, via aerosol, 200 meters.
Aerosol, okay, because of the physiological media.
Yeah.
Physiological.
They are droplets. Okay. Exactly, they are droplets.
Okay, the droplets. Well, my movement now to MVRI is they need to do a lot of work to get us the pathotypes and the serotypes.
Yes.
Of these organisms. I was there on 3rd February. I gave them a lecture from my own field simplicity, from a layman point of view. Because it's in discussion and conversation like this, they'll be able to throw up a lot of research. Clinicians cannot work in isolation from research.
Exactly.
And all these things you are mentioning today about serotype, pathotypes, and immunotypes. But what I want to tell the first speaker is this. I'm not a researcher, but I can give you clue to research. It was talking about arthritis, arthropathy, and my understanding of organisms that do not have predilection on joints. When they will start developing problem it's an indirect problem. Maybe from the third type of hypersensitivity. So let them look at reactions, antibody reactions that flowed to those joints. This can give them a clue to what is causing that pathogenicity at an aberrant site. Because the joints are not aberrant sites of mycoplasma, apart from mycoplasma synovia in chicken. So maybe let them look at antigen or even the second type of hypersensitivity. Hello, let them look at the second type of hypersensitivity and the third type of hypersensitivity. Might be that is what's causing it. And you are very brilliant in discussing chemotherapy of of CBPP. And then in all mycoplasma, I've never seen any mycoplasma as chemotherapy. They might go shutting it down, but it's coming up again.
Yes, well, it's coming up, yes.
When you shut it in poultry, I'm discussing poultry because that's why I'm a major.
Thank you. Thank you so much, Dr. Charles Ibe.
I ran away
this
from
is really interactive. I must say from my end,
yes,
I'm enjoying the interaction.
Sincere, don't block out elders when elders talk.
So I'm not blocking you. I'm just telling you that I'm enjoying the interaction. That's all.
When elders talk, all you think is so that you learn to be elder and you will be an elderly elder. Anyway,
so I'm just actually commenting how interactive the session is. I wasn't planning to block you.
Yes. Okay. So you're a better veterinarian than me because you're a professor, and then probably I'm a marketer and a farmer. And your area is very dangerous. Cattle. I ran away from cattle kick and horse kick, and that's why I went to poultry. So that when poultry kicks me, I will survive. Okay, so shut me down. I'm okay.
All right, thank you very much, Dr. Charles Ibe. It's always fun listening to you talk, sir. So, so I'm going to unmute one more person who was raising his hand. Okay, I can see that Dr. Ada Oguchi.
Yes.
Okay, let me unmute you so you can give us 2 minutes. Dr. Ada, the floor is yours.
Yes, can you hear me?
Yes, we can hear you.
Good afternoon, everybody. I think mine is just to mention that, just to share an information, that I am aware that there is a lab dedicated to research on mycoplasma in Nigeria, domiciled at the University of Ilorin Veterinary Teaching Hospital and funded by some researchers in the University of Edinburgh in the UK. So the head of that lab is one Dr. Lauren Scholler, and basically all they do there is to work on mycoplasma, especially CBPP and CCPP and the likes. For those who might be interested in running samples or in some investigations that MVRI might become too difficult to access, or maybe because they want to run it rather quickly, that's one place that you might want to pitch your tent. I think they have facilities all the way up to PCR for diagnosing mycoplasma, and I thought I should just share that information.
Okay.
Thank you so much, Dr. Ada, for that information. I'm sure we all grabbed it. University of Ilorin, so they have a designated lab for mycoplasma screening. So that's good information. So I can't see any questions coming up. So sir, as one of the hub experts for today, I will give you 5 minutes to give us your recommendation, a list of what all of us on this platform can take home and add to our already existing knowledge on CBPP. Professor Okaito, you have the floor for the next 5 minutes. Thank you, sir.
Okay, you are muted, but then maybe I'll be able to, I see the direction you're going, My take in this, in conclusion, I would have loved a scenario whereby MVRA will wake up, one, okay, and then go out to the field, find out the type of serotypes we have. Because if you look at this T144 vaccine that has been in circulation, it's been there since in the 80s. And of course, diseases mutate, they change, so we must be current with the disease itself. So one, let them go out, screen these animals nationwide. They have the mandate. They can do it in collaboration with Federal Livestock and Pest Control Services. Because I was privileged to participate, in a program, they call it LPRESS. They were trying to, come up with a document for the control of CBPP in Nigeria. And of course, to see how the disease can be controlled. Okay, but then before that comes up, I think the NVRI owes a duty to tell us the number of serotypes we have in this country. And of course, vaccines control must be put in place so that not every Tom, Dick, and Harry will go to the market and buy CBPP vaccine and then go and jab. That way, you know, we are further creating more problems. Okay? So that is my take on this thing. Otherwise, it's a disease that can be controlled. If other countries can exterminate it, I don't see the reason why Nigeria cannot. But as we are today, you know, the disease is endemic. There is hardly a herd of cattle you will go and scream, you will not see CBPP. So what are we doing? Thank you very much.
Thank you very much, Professor. So for a disease that is ravaging and costing so much economic loss, yes, I think this is a wake-up call to all stakeholders, yes, in the research, in clinical practice, policymakers, so we can all wake up and play our part to make sure we bring an end to this disease that is costing us so much, millions of dollars, millions of naira. It depends on where you're. Okay, while you were giving we're answering the questions, I saw Dr. Gani Enahoro join. Thank you for joining. You're welcome, sir. And at the end of it all, what we all need to take home is this is a disease that can be treated, that can be prevented via vaccination. Because for me, you know, you come up with treatment regimens for certain diseases, but if at the end of the day, you're going to leave longers in the herd who will continue, or carriers as they call them, who will continue to spread this disease in the herd, then the best thing to do is to prevent the disease entirely from even coming up. So this is a wake-up call for everyone. And we have just some few minutes to go. The session was meant to last for 90 minutes, but we're Nigerians, so we can go a little overboard, but not too far. And I also want to recognize the acting registrar in person of Dr. Oladotu Fadipe. Thank you so much for joining. We have about 127 participants. More than that, we had some join and some leaving along the line, but this is for me, this is one of the most interesting sessions we've had. And so the next thing after the expert's recommendation is just for us to take the post quiz. It's the same question as the pre-quiz. Can we have the screen, please? Okay. Post quiz, yes. We're going to take it for just 3 minutes. Can we have the questions up, please? Okay, so you have 3 minutes to answer the questions. They're just simple, straightforward questions. I implore you to do that. This is just going to help us measure the knowledge gained before and after the presentation. Thank you very much. 19 seconds, and nobody has attempted. Ouch. Okay, yes, now we have people attempting. Okay, so we have 3 minutes. I'm sorry about the noise. It's raining heavily here in Kaduna. Okay. 1 minute's gone. We can all do better. Okay, 17%. We can do more. This was an interesting session, so we should all be excited to partake in the post quiz. It's fun, actually. For those who were not present when we had the pre-quiz, so you're answering based on anonymity. So your name is not going to show, your number isn't going to show. We just want to use the data to measure the knowledge shared and gained at the end of the session. Thank you. We can do better. 40%, 41%. Coming up. I want us to get to 50% and possibly more. Okay, it's coming up. We have less than a minute to go before we take down the polls. So you can quickly just answer the questions. It won't take you more than 10 seconds to answer the questions. Okay, so we just hit 50% participation. I'd ask for more. We have about 20 seconds before we take down questions. Okay. Just a few seconds to go. And I have 57%. I think we can do more. 60% will be bad. Okay. And we have 59%. Can we just answer and give me 60%? Anyways, thank you all for participating. It was really informative and interactive for me, and I'm sure for everyone else. Can we take down the poll question? So thank you so much. It has been an interesting and interactive session. I want to say a very big thank you to all our hub experts, the case presenters, our elderly statesmen who took out time to join and contribute to this session. Looking forward to more interactive sessions and informative sessions. The ECHO model is big on bi-directional flow of information from the experts and the participants, vice versa. Thank you so much for the presentation, Professor S.O. Okayeto. Thank you so much, Dr. M.B. Babashani, Dr. Robert Joshua, I got the name right, and every other person who contributed. Thank you so much. And so the next thing on the agenda is just announcements and next step.
Dr. Tumsia, you don't want to share the answer to the post quiz?
Oh, okay. I'm supposed to. Apologies.
Maybe there was 0%. Maybe they all failed.
Dr. Babashani, are you still with us? We're actually supposed to answer the questions together. I missed that part.
Okay, I'm with you.
Okay. Can I have the questions so we can just read them out and see if what we answered and what the answers are from our hub experts? Can I have the questions up, please?
All right, so Dr. Tumsia, I think I can see the questions.
Okay,
wondering why you cannot see the questions. So maybe I can just quickly take this. The first question, what is the causative agent of CBPP? There's Mycoplasma bovis, there's Mycobacterium bovis, there's Mycobacterium mycotis, subspecies mycotis, there's Mycoplasma mycotis, subspecies mycotis. What's the answer, Dr. Babasha?
So D is the answer.
All right, so impressive. 77% of the participants actually chose D. So you said D is the answer, right?
D, yes. Mycoplasma mycotis, subspecies mycotis.
Thank you so much. The second question, the following are means of transmission of CBPP except the first, indirect contact with infected animals, direct contact with infected animals, fomites, and lungers. What's the correct answer?
The answer is C, fomites.
Fomites. Now I think we need to take the class again because just starting. So you know when I saw the questions, I knew it was said by a university lecturer. So you need to be careful. So just 30%. And the next question, CBPP is preventable through vaccination with TC vaccines, antibiotics injection, strict biosecurity without vaccination, swamping out. Which is the correct question? Answer.
That's A, vaccination.
Fantastic. So I think everybody listened to this. 84% of people got that correctly. Number 4, the estimated financial loss due to CBPP in Nigeria is 20 million, 250 million, 200 billion, 2.8 billion. Which is it?
2.2 billion.
All right, so 46% of participants, which is actually the highest in the option. If you had written 80 billion, maybe there would have been a lot of confusion. But thank you, 46% got it. The 5th question, which is slightly very dicey also, the chronic form of CBPP is characterized by the following signs except pyrexia, wasting, coughing, polyarthritis. Which is the correct answer?
Okay, I'll say A.
All right, so a session. I would have loved a situation where Dr. Tumsia, if you will, and then you can now wrap up with the announcement.
Okay, Dr. Femi, 30 seconds each. So Professor Caleb Kudi, the floor is yours for 30 seconds. Thank you, sir.
Network.
Okay, so I think Prof's network. Okay.
Presentation. Can you hear me?
Yes, you're breaking, but we can pick out a few words.
Can you hear me?
Not clearly, sir. The network is breaking.
Can you hear?
Oh, yeah.
I don't think the network is. So maybe we can move to the former director, MVRI, to take 30 seconds from you, sir. Can we unmute him, please? I think Prof. Caleb is having issues with his network.
Good afternoon to all.
Good afternoon, ma'am.
Sorry, David. My name is David Shamaki. My voice is feminine, so but it's David Shamaki is the name.
Oh, sorry, my apologies. I totally heard something different.
Just to react.
So the floor is yours for 30
Professor
seconds.
Kaito, in his closing remarks, talk of going to the field for surveillance. As of the time I left BOM, there were over 1,000 isolates of CBPP in MVRI. What we had, and then some of them were quite different from the vaccine strain. So there was an attempt to initiate. I visited Muguga in Nairobi, and they were doing subunit vaccine research for CBPP vaccine production because of the diverse nature of CBPP isolates they also had. So we tried linking up with them, but with the advent of COVID, funding was a big problem until the time I retired. So definitely VOM is doing a lot of surveillance because we have a lab for CBPP vaccine. We were involved in a lot of testing before using ELISA for that matter, which, So the next test really is that because CBPP vaccination is a problem, so you still need to check and see whether the diverse isolates that we have, you can get enough information to produce subunit vaccines, whether polyvalent or univalent, depending on what it is. But the major problem we have on ground is the diversity of what is on ground now.
Okay, thank you very much, sir. At least we have an update, because most of the times the problem is we don't really get to hear all of these things happening. So everybody just assumes nobody's doing anything. But with this information, now we know that MVRI is on top of the matter and trying to make sure the right thing is done. I don't know if Professor Caleb Kudi's network will permit him to give us his own 30 seconds bits. Professor Caleb Kudi, 30 seconds. Can we unmute him, please?
Hello, can you hear me?
Yes, we can hear you, sir. Good afternoon. Okay, I think his network is still not permitting him. But before I call it a day for all of us, I picked out, okay. His network is terrible. I picked out Dr. Babashani. I don't know if he was.
Okay, thank you very much. Sorry, you did not.
Okay, now I think the network just bumped him out. So somebody suggested the use of certain medium to make sure we get the information on how to manage these cases when Fulani herders or livestock farmers cite some of the signs and symptoms. And somebody mentioned using radio. That is not really a bad idea. So officially, I know a lot of people have seen it. We launched the Farm Alert Media, I think about 3 or 4 weeks ago. Forgive my lack of accuracy. We launched the Farm Alert Media. So this is a call for volunteers out there who can come up with programs to make sure we pass out the right information to the right group of people at the right time. So I wouldn't mind someone coming up with a program in different languages, Hausa, Igbo, and Yoruba, to help these farmers understand what's going on, the Fulani herders, what to do when before they call in for veterinary assistance. So we're calling out to volunteers to create programs and make sure we strengthen the animal health system in Nigeria and Africa at large. Thank you so much. Quickly for a minute, you can drop it in the chat section. What other topics would you want us to address? What other topics would you want us to discuss on this tele-education series? The chat box is there. We just give you 1 minute and we're going to extract your suggestions and we're going to work with them. Thank you so much once again for joining. I hope we all got enough valuable information to go out there and share with our spheres. And okay, some more questions are coming. We'll put them down and possibly get answers to them and share with you. Okay, we're getting suggestions. Keep them coming. We're going to take them for just a minute at most, and then we call it a day. We're supposed to have this for 90 minutes, but we just went a little overboard, but I think that's fine. Okay, we're getting suggestions. Okay, keep it coming. ASF, that's African swine fever, okay. Thank you so much, everyone, for joining. I think that's it. And okay, we still have some coming. I can see a lot of ASF. Please do follow us on all our social media platforms, YouTube, LinkedIn, Facebook, Instagram. All you have to do is just type Farm Alert and we're there. Send in your suggestions, send in your comments, your compliments too would be good too. Thank you so much. Have a nice day. Bye. Thank you for coming.